Drill guides based on 3D images and virtual plans have been used in implant dentistry for 2 decades. All commercial guides share a similar design, employing a guide tube to transfer the drill trajectory from the surgical plan to the patient. While tube guides work well in many cases, their design confers limitations which restrict their use. They often cannot be used in posterior areas due to vertical space requirements. Stacking the drill above the tube requires about 10 mm more vertical clearance compared with freehand drilling. They often block visual and physical access to the site. For this reason, guided surgery has become synonymous with flapless surgery, in spite of the fact that flap reflection is indicated in the majority of implant cases. And lastly, they cannot be altered at the time of surgery if needed. This presentation describes a tubeless, 3D-based implant drill guide system which overcomes the limitations of commercially available tube guides. The system consists of CT-derived, vacuum-formed ThinLayer and tube guides, as well as custom disposable drill stops for depth control. The ThinLayer guide is very much like the model-derived vacuum-formed guides we have all used, with several significant differences. The guide hole is CT-derived from implant planning software and defines one point of the implant trajectory. The top of the guide hole is manufactured at a predetermined height from the implant platform and mates with a drill stop to provide depth control. The side of the guide is open, allowing flap reflection and clear visibility of the surgical site. An implant trajectory is defined by 2 points, as in the top and bottom of a guide tube. In contrast to a tube guide, the ThinLayer guide defines the 2 points of the trajectory separately and sequentially, employing a bleeding point or shallow pilot hole, and secondly, a guide hole in a ThinLayer positioned 8 to 10 mm above the surgical site. The following case illustrates the usage of the ThinLayer guide system. This first case is a second bicuspid first molar case. The surgical plan is based on the opposing dentition as well as 3D visualization of virtual teeth and the patient's dentition and soft tissue. The tube guide is placed and a bleeding point is created by passing a spear drill or endofile through an insert in the tube guide. The tube guide is then removed. A ThinLayer guide is inserted and a spear drill is placed through the guide hole. The tip of the spear drill is inserted into the bleeding point and a 3 to 5 mm deep pilot hole created. Should the position of the pilot hole require change, the pilot hole can be enlarged in any direction and the ThinLayer guide can still be used. If one were using a tube guide, if the entry point or the pilot hole is changed, the tube guide can no longer be used. Subsequently, drills with increasing diameters are placed through the guide hole. The tips are inserted into the pre-existing pilot hole, and the osteotomy diameter increased appropriately. As you can see here, the drills can be inserted through the guide at an angle and then straightened until their tip is in the previous hole, requiring the same vertical space as freehand drilling. There is clear visibility and access to the surgical site for flap reflection, and the guide can be used to center a cortical drill, a tap, and an implant driver. Self-tapping implants can sometimes find their own way in Class 3 bone, and guiding them with the ThinLayer guide prevents the implant being inserted off-angle. As shown here, the implants are placed in an ideal position, which is verified by the alignment of the guide tubes with the implants. The next case is a lower second molar case, which could not have been done with a tube guide due to a vertical space limitation. A bleeding point and pilot hole were created, as in the previous case, using a spear drill through an insert in the tube guide, followed by the spear drill and a drill stop in the ThinLayer guide. Twist drills with drill stops were placed at an angle, straightened, and placed into the previous osteotomy to depth. As shown in these slides, the implant position is optimal and replicates the position that was determined in the surgical plan. The final case is an upper central incisor case in which the surgical plan placed the implant two-lingual. As in the previous cases, the tube guide was used to prepare a bleeding point, followed by a ThinLayer guide through which a pilot hole was created. As shown in this slide on the lower left, due to a planning error, the pilot hole is slightly too far to the lingual, and as shown in the lower right, was therefore moved slightly to the buccal. Although the position of the pilot hole was changed, the ThinLayer guide was still usable to guide preparation of the osteotomy and placement of the implant in an ideal position. This could not have been done with a tube guide. In summary, the ThinLayer guide system overcomes the limitations of conventional tube guides. It allows flap reflection or flapless surgery, requires no more vertical clearance than freehand drilling, provides depth control, allows changes in entry point at surgery, can be used as a traditional tube guide, is not proprietary, can be used with most standard implant drills and implant systems, and uses free implant planning software. This system provides a versatile, simple, cost-effective guided surgery solution. The ThinLayer system has been designed to eliminate the technical and financial barriers to adoption of guided surgery and make guided surgery feasible for any interested implant surgeon. Thank you very much for your interest.